graduates from the US who have traveled afar to be here with us, so a big warm Malaysian welcome. And for many of us, it's certainly in the Malaysian setting, it's probably one of the first in-person meetings after 2.5 years, something to be very excited about today. So over the next 3 days, we'll be talking implementation science 101 from basic to advances with a local context of implementation research, human rights, and stakeholder engagement. And we're trying to answer those important questions of how, why, and of bridging that essential gap between science and practice and implementation. So before I introduce the opening remarks, I'd like just to mention a couple of housekeeping rules for the facilitators. So firstly, I'd like to ask the speakers to keep to timing of the agenda. I've been warned about that many times. And a bell and light, you have 2 for the price of 1, will take effect at the end of the session. For other housekeeping rules, there's a prayer room located in level P1. Parking ticket validation. There is a parking ticket just near the lifts on the outside, just as you head towards the lifts. You can just put it in the machine and you get that flat rate. So it's on the way to the lifts, just outside the lift area. Coffee and tea and snacks are available all day from outside the ballroom. There's a breakout session after the lunch break. Half of you will stay here and half of you will move into the next ballroom, which is directly adjacent to us. And you've been already pre-assigned by the color of your tags. We'll talk a bit about that later. And participants to return to this ballroom after the breakout session for the summary of each day. And there'll be a dinner announcement at the end of the day, and we'll make give you more information about that at the end of the day. So without much ado, I'd like to introduce Prof. Adeeba and Prof. Rick, both of whom do not need any introduction, to welcome you and open the conference. Thank you very much.
Good morning, everyone.
Good morning, everyone. We're really excited to have you here.
Doing this duet. Yeah, so like Iskandar said, it's really exciting to be together again after 2.5 years of COVID restrictions, and especially to welcome our distinguished speakers all the way from Yale. I think some of you may have joined the online version of this bootcamp last year, but I think it's going to be much more exciting to be together and learn together over the next 3 days. This bootcamp is really a culmination of Rick's and our, CERiA's collaboration with Rick and his team from Yale. We've had over, yes, Rick can tell you all the details. I'm not very good with numbers. Many years of collaboration in HIV, working with key populations and prisons, and through that we know that to do some of the programs that we want to do here in Malaysia, we really need to infuse the science and the theory behind implementation research to do it better and to also enable us to learn from it. So when this opportunity from Fogarty came about to put in an implementation science training program in Malaysia, we grabbed at it, and many of you may not know this, apart from many things, Rick loves writing grants. So if you have a grant that you need writing, call him. And before we know it, we got a great score, of course, and here we are. In addition to this also allows 2 PhD students from UM and 2 of our faculty members to go to New Haven to have in-house training over in New Haven. It's a fantastic opportunity, and the idea is, to immerse them even more in the science of implementation over in New Haven. I wish I was young enough to do that myself, really. Maybe I will, next year. But I hear that it's a really tough program, and so maybe not. a lot of studies. So with that, I'll pass it over to you, Rick, and I hope all of you will enjoy, but also learn much from these 3 days. It really is implementation. If you look at the program, it's implementation science on steroids over 3 days. Over to you.
So good morning and welcome. And I just want to say what a long, strange, wonderful journey it's been. I met Adeeba in 2005, so I will do the math and say that it's been 17 years. And I feel as though Adeeba and I were siblings separated at birth. And we found our way back together, actually at a meeting in New York, where I invited her to New Haven to come see our program without even knowing her name. So talk to strangers. To those of you around, each and every one of you, there might be something that may grow out of just this collaboration. This meeting today is the culmination of those 17 years of coming together, generating ideas, having a long-standing relationship. And you're going to hear from some of our colleagues from Yale, indeed, about these long-standing relationships and how important they are for doing this work. And while implementation science, as you will learn, is a relatively newer area of science, it's changed its names, but it's found its way into the field. What we're hoping to do over the next 3 days is to really instill some of the theory and the practicalities, because what is really important is that each and every one of you are implementers, right? And so having some of the sort of theory behind it and some examples and to be able to move forward to do what you do better, faster, and cheaper is going to be the wave of the future. And so I just am so thrilled to have you all here. What often happens at conferences is we thank the people who do all of the work at the end. But I'm going to reverse that a little bit, and I would like to have 2 people stand up at this front table, Paula Delamira and Romana Saiki. I'm going to basically say that these 2 people were up on calls almost every night at 9 o'clock in the morning, 9 o'clock at night, having conversations. We've got some other people, Clara, Jay, a whole bunch of people at the meetings. We have our colleagues who are creating the sort of the whole activities today, and I just really want to give them a big round of applause. I'm also really grateful to my colleagues at Yale, who I have had the luxury of working with for a long time, and I'm so glad to have them here. Nazi Lamak, they will have more of, for sure. We will have a good time here. And I also, most importantly, want to thank each and every one of you all for taking the time to be here for the next 3 days. And, of course, look at the wonderful environment. Our colleagues from the Hilton, who have been really generous to both of us for a number of years, have really allowed us to make this happen. So I want everybody to come with open eyes, open ears, and open hearts as we begin to learn and work together for the next 3 days. Thank you so much.
So I'd like to welcome to the stage Sten, who's going to be giving the keynote lecture of the day, entitled Closing the Gap in Health Research, What Role Can Implementation Science Play? Sten is a pediatrician, infectious disease specialist at Yale School of Public Health. His work is focused on increasing healthcare access to all, prevention of mother-to-child transmission of HIV and sustainability of HIV programs. And additionally, of late, we've worked with schools and other programs to provide guidance on COVID prevention within institutions. Thank you, Stan.
Thank you very much. Great pleasure to be back in Kuala Lumpur, an extraordinary city and an extraordinary country. I thought I'd do a couple of autobiographical comments about how I ended up working in implementation science. Give you a couple of case studies of projects in which I think we chose the right methodology, implementation science, to tackle the challenges that faced us. And a final comment on science communications and community engagement. I've worked in Asia, but largely in epidemiologic studies. My implementation science work has been in Africa, so you're going to get some African examples today, and hopefully they'll be interesting. This is an old slide. I think I found this 35, 40 years ago, and I've been using it ever since. Because there are more elegant social ecology models, there are all sorts of ways of making this more complicated, but frankly, as a clinician, many of you are clinicians, we look at the behavior and biology of the individual, and if we're especially enlightened, we're engaging the physical environment, social environment, but awareness of access to quality healthcare, awareness of how societal policies and interventions affect individual health is a vital part of what one might think of as social medicine or preventive medicine or enlightened medicine. So I started out focusing on children growing up in poverty. My first two international projects were in Nicaragua and in Puerto Rico, which is actually a territory of the United States. I worked on schistosomiasis and on malaria. And from those days on, I've had a passion for disease control and prevention. Just the notion that one can operationalize programs and have disproportionately large impact on disease incidence and severity beyond what one can manage in a clinical environment where one is simply waiting passively for a patient to come to one and one is caring for them as best we can. Am I making those clicks, or is that coming from another source? Okay, I won't worry about it. But I did have a career shift working on population ecology and parasites because I was in New York City in the 1980s. And my first AIDS patient was a little boy, about 5 months old. His mother was already deceased. His father was not in the picture. He had no relatives or visitors in the entire month that I cared for him. And the nurses were frightened to feed the baby because we were so ignorant of HIV in those days. But that was quickly solved with education and modeling. And that was just sort of a 24-hour crisis that we were able to alert the nurses as to the feasibility of caring. And the child had oral and esophageal candidiasis, the worst case that I had seen, will ever see. I had virtually no T cells. He cried a lot, but there was no sound. He couldn't swallow his formula, and he died. And I was also called upon not only the emotionally wrenching feeling of caring for children, all of whom eventually died in that period, but also my colleagues in internal medicine who were caring for a very large population, initially men who have sex with men, but soon thereafter women and persons injecting drugs. We had a lot of persons with hemophilia, etc. So it was a terrible and scary time. And it really was like a tsunami that came over our city. I helped establish an adolescent HIV clinic, the first one in America. It was something that was neglected at the time that we established it. Perinatal infections were skyrocketing as the number of women who were infected was skyrocketing. And my catchment area was the South Bronx and northern Manhattan, where I worked for 14 years. I switched jobs in 1988 by moving to the NIH and working for Tony Fauci as the epidemiology branch chief, and then epidemiology and vaccine trials when they wanted to mobilize vaccine trials. And we had tremendous cohorts for MSM, for WIP. We started a women's cohort, started an adolescent cohort, and ICHD, one of the other institutes. A lot of work in PMDCT. We expanded our work in Africa and Asia, looking at the impact of ART because this was the monotherapy era. We thought we had a tremendous breakthrough with zidovudine, which we did, but we didn't realize how transient the benefit would be because of the generation of resistant viruses. So the dual therapy era came in about, we had zidovudine about 87, we had dual therapy about 92, and then triple therapy not until 1996. And I had friends, colleagues, classmates, even my research assistant died days before they could get to 1996. The stigma and social determinants were prominent in this disease, and I eventually returned to academia, where I predominantly worked on clinical epidemiology and later on infecting implementation sites. This was one of the influential elements, was the fact that if you could, I pressed there. So what, if a pregnant woman had a high viral load and no therapy, she had about a 55% chance of transmitting the virus to her infant. But on the other hand, if she had an undetectable viral load on therapy or not on therapy, she had virtually no chance. So the notion of driving viral loads down was an exciting one, and the ACGG 076 study showed that zidovudine by itself could be helpful. We had the HivNet 115 study that said that single dose therapy could be very helpful, dropping transmission rates 2/3 and 1/2 respectively. Today, of course, we just treat all pregnant women with comprehensive therapy and can reduce transmission to near zero. And that's what happened in the US. We had a plummeting of cases, and pediatric HIV is no longer a substantial public health problem in the United States, nor is it a substantial public health problem here in Malaysia, because you have had tremendous successes, really model programs for all of Asia here in Malaysia. I was on an Institute of Medicine report that recommended routine universal voluntary screening in pregnancy, and it's funny to see it there because the report was so controversial. We had so much opposition, even on the committee. And I and another individual were kind of the Miltons, saying this has to be routine screening for women. And we had people of goodwill who said this will stigmatize women, this is not going to be accepted, etc. But I just was wearing a sort of women's health advocacy and nutritionist hat, and it just made sense to screen. So we got the recommendation through, and it was one of those tipping point moments where there's tremendous opposition. A year later, everybody agrees with you. So don't ever shy away from taking the right stand, because you will bring people along with you. Now this model from the U.S. Census Bureau was produced about 1999, and they had the impact in a decade from 2010 from year 2000 to year 2010, and how much child mortality in children under 5 was going to be in these six African countries. And you can see the vast difference between child mortality with AIDS or without AIDS. And there really was no other disease that had that level of impact. I mean, malaria is awfully important, real diseases, but they're somewhat more endemic. This really had an epidemic form, and this galvanized us into action. So I started working in Zambia. Most of you know where Zambia is. There it is on the Africa map, and Victoria Falls, and we were working in Lusaka. There were 26 clinics in the city, 10 birthing centers, about 33,000 deliveries, about 2 million outpatients this year in that infrastructure where we were working. And there are really 3 pediatric strategies. One is primary HIV prevention. And I've been interested in that my whole career because I've always thought, as you always will think, that the best way to avoid perinatal HIV transmissions from mother and father not to get infected to begin with. So this is very much a continuum, and that obviously is a huge priority. I've worked with the HIV Prevention Trials Network for now, my goodness, a couple of decades on that theme. A second is preventing unwanted pregnancies. If an HIV-infected woman does not want another child, you could do a great service by helping her access contraception so that she doesn't have an unwanted child. And that will also be HIV prevention in the child. And then prevention of mother-child transmission during late pregnancy, labor, and breastfeeding is the PMCT-CT agenda that is more familiar to us. But I mentioned number 1 and 2 because it's often not mentioned. And people say, well, the way to prevent transmission in children is PMCT, but no, there are other ways. This was a cascade that we sort of conceptualized back in the early noughts, where you have to identify an HIV positive woman. She has to have access to your services. You need to offer her the intervention. She has to agree to the intervention uptake, but then she has to adhere to the intervention later on, because you're with single dose of nevirapine, which is what we were using back then, single dose for mother, single dose for baby. She was going to take the medicine when she went into labor. So her uptake decision node was at a very different time than her actual adherence decision. And it was surprising, really, how often women were not at home with their medication when they went into labor, or they'd given their medication to a loved one thinking it might help them, or they were ashamed to take it because they were with family. So a lot of reasons why you didn't adhere, even if you intended to. And then the mother and the baby both have to have been given ART. So your postpartum unit, the nurses in that unit had to know exactly who the HIV-exposed babies were so that they could get their nevirapine dose. And so there was a lot of work to be done. Something that looks fairly simple actually was not. And the interesting part, when we did a citywide surveillance study in a sort of first step of an intervention science effort, we found that because we were in an urban African setting, we estimated about 90% of women were actually coming into care. The other 10% were going to traditional nurse midwives and never coming into our system. 80% were offered intervention, 75% agreed, 70% adhered, 80% of the babies were correctly identified and given the drug. But that means we only had 30% program coverage. And the importance of this work was that I thought we were managing about 60%. So in a sort of informal assessment, without the hard numbers, I was overestimating the coverage of our program by a factor of 2. And if we hadn't done this study, I'm not sure we would have had the successes in Zambia that we did. And those couple of references if you're interested. To make a long story short, different clinics had different needs. So the ones where only 80% of the women were being offered the intervention, there was occasionally a nurse who was a testing skeptic, or some other element in that clinic that was leading some inefficiency in registration. So we had to fix that. Other places, like the uptake of interventions, there was often community work that had to be done with the husbands, with the political or religious leaders of the community, because women were not agreeing, mostly because of community forces. Adherence, we did a body of work that demonstrated that women could actually get their nevirapine right when they come into labor and still prevent HIV, so that if a woman didn't adhere, we could immediately give her the medicine. That was a whole body of work to prove that that would work. And then reorganizing postpartum data infrastructures to make sure that every single woman whose baby needed the nevirapine was identified and correctly given the medicine by the nurses. So let me move to a rural project. This was in a remote rural part of Mozambique. It is probably the third most rural. Probably the largest city is only 200,000 people out of 4 million. And beyond the 200,000 people, the only cities are a handful of 50,000. So many villages, many very small cities. And we sometimes had to get to these clinics by boat, and the waiting lists to see the nurse were very long. Mozambique is one of the less capacitated countries in the world, and it was virtually completely nursing-led system. They didn't have very many doctors. So here's one core function: assessing folks, assessing communities, monitoring health status, diagnosing, investigating problems and health hazards, evaluating effectiveness, accessibility, and quality of services. So here's an example where we had an unacceptably low proportion of babies born to HIV-infected moms who were being brought back to the clinic by their moms. Only 50% of the mothers were coming back for their own care, and only 25% of the babies were being brought back to the early early intervention clinic. And this was shocking because, as everybody in this room knows, moms do much better for their babies than they do for themselves. So we figured there was something very strange and amiss. So based on a medical student, Rebecca Cook, and then based on a young quality improvement guru, Phil Ciampo, working with our Mozambique colleagues, we did a process map, which most of you are familiar with. You carry the woman through her visit to the birthing center, and she delivers the baby, and she's discharged and referred to the early intervention disease clinic, which is what they call the AIDS clinic. And she was supposed to come back in a month. And most of these were like 15 meters away from each other. I mean, they were in the same compound. So it doesn't seem too complicated to explain. But when we did the process map and then walked moms through this, and also we interviewed moms, we interviewed nurses. And the mothers and the nurses told us exactly the same thing. Exactly, this is medical anthropology. Exactly the same thing, which was they don't understand what they're being told because the women in this region have a median time of formal education of 2 years, and their Portuguese is not good enough with 2 years of education to understand a message that you have an infection even though you don't feel sick. Your baby might or might not be infected. You need to come back for some molecular diagnostics in a month, and you have to go over to this clinic, et cetera, et cetera. You see what I'm getting at? So the nurses told us what we should do. And that's the next slide, which is don't discharge them from the postpartum clinic. Walk them, when they're ready to go home with their newborn baby, walk them over to get their counseling in the EID clinic, enroll the infant and the mother, and then discharge them home. So we did this, and this was the result. So the standard referral getting us about 35% follow-up, and we doubled it essentially, and we did much better than this. This was just the first 2/3 of a year follow-up in our study, but within 2 years we were getting almost everybody coming back. And as a pediatrician or as an obstetrician or as a nurse, You could be working really hard in these clinics and not get this kind of impact. This requires implementation science. It requires you to find what structural deficit there is to fix it. And if we hadn't done the quality improvement work, if we hadn't done the qualitative work, we wouldn't have known that women didn't understand what they were being told because they speak the local language well and they speak Portuguese poorly, and they didn't know where to go. It wasn't that they didn't care for, it wasn't any more complicated than that. It wasn't some big stigma and the headman of the village was prohibiting them, their husbands were preventing them from coming. It wasn't any of the heavy lifts. It was a very light lift. Just fix our own program and have people come back. A second theme of public health is policy development, policies and plans that support individual and community health efforts. Enforcing laws and regulations that ensure safety. This certainly has loomed large in the COVID era. And research for new insights and innovative solutions, which is where you all come in. This is where implementation science is so essential. So we've done some work now in Mozambique around drug stockouts. This is an ugly little secret of the big PEPFAR program. You may have heard of the PEPFAR program, President's Emergency Plan for AIDS Relief, which is now over $90 billion of investment, the largest single disease public health investment in world history, and has made quite a difference. But these are the adult drugs on the top, pediatric drugs, and TB drugs. And you can see every time there's a black or red, you have a stock out or a very close to full stock out, imminent stock out, and you can muddle along with the yellows, and only green is optimized availability. So something as seemingly simple as I would like to come back and get my medicines for my tuberculosis therapy, or my child who's got HIV, or myself, and the probability that those drugs are not available in the clinic. We also looked at test kits, same story. I want to be tested for HIV, I'm sorry we have no test kits today. So despite these huge investments, because of supply chain deficits and a lack of coordination between Mozambican and US government entities, we were facing these sorts of shortages. We also realized how difficult it was for subsistence farmers and subsistence fisher folk to take a day off from their fishing or their farming to go a long distance to get HIV care. So we went to them. We took the motorcycle, stocked it with the test kits and the drugs, and if there were at least 6 individuals in a particular village, and it was more than a couple of hours walk, we would then go out to them and have a clinic under a mango tree and provide that. We also took a page out of the discovery of Médecins Sans Frontières, the Doctors Without Borders, who had these groups. So a single farmer would come for himself and his 5 neighbors and get all the drugs, get his CD4 or viral load, and then not come back for 6 months, but still get his drugs from the next farmer, the next farmer, the next farmer, those sort of group arrangements. So we were able to just make it easier for people to stick with their drugs by not forcing them to take a full day off from work, which it's hard to imagine, but there are people whose families may not eat well on the day that they don't fish. Now this is just a sidebar slide, just to let you know that sometimes as you're doing this work, you gain insight into methods that need reform. So I had 2 biostatistical colleagues, and I made some offhanded comments saying, these stupid papers, they all have different definitions of loss to follow. And how are we supposed to compare? And that was just, I was done with my stupid comment. That was my insight, that these papers were wrong. Well, these biostatisticians came back to me the next day and said, Sten, why don't we harvest all of the loss to follow definitions that are in the literature and apply them to our own Mozambican data. Apply all, and we found 17. And this is what you see. We could, with one definition, say that we had 20% loss to fowl at 24 months. And with another definition, we could say we have 80% loss to fowl in 24 months, and every number in between. So it gives you insight as to how critical definitions are in implementation science. Because one person's loss to fowl is not another person's loss to fowl, and we would never accept this kind of thing in laboratory medicine, where this person's CD4 might be with one machine and this other's with another machine, and they're off by 200 cells, and what do we care? No, we kill ourselves to synergize the definitions within our medical field and our laboratory field. Why are we so sloppy in public health and implementation science? So this is just a little sidebar. The third core public health function is assurance. Assuring people that they can get care, linking them to needed services, assuring a competent workforce, informing people about the health issues, and mobilizing community partners to get the job done. Now, you might think, well, with all this PEPFAR investment, have we made progress with PMPCT in Africa? Well, we certainly have. Tremendous progress. However, this says where the current cases are. Nearly a quarter of the current babies born infected with HIV with failed PMPCT are in one country, Nigeria. And Western and Central Africa is a little more than a quarter. And Eastern and Southern Africa is a little less than a quarter. The remaining regions of the world, a tiny fraction. And 10 years ago, Eastern and Southern Africa, the yellow up in the upper right corner, would have represented 2/3 of this distribution. So in Southern Africa and Eastern Africa, we've made tremendous progress, but we've got a long way to go in the lower prevalence zones and lower consciousness, I would say, in West Africa and Central Africa in particular, including Nigeria. Now, allied diseases are absolutely critical in the ART era. We have non-communicable diseases, everything from cervical cancer to hypertension and 20 other diseases that ought to be screened for in HIV-infected people. We have many other infectious diseases, notably tuberculosis and sexually transmitted infections, that should be integrated into HIV programs. And we have diseases linked to chronic inflammation and aging. Even the well-controlled HIV-infected individual does have chronic inflammation. We can measure that even in people who have no detectable viral load. So short of a cure, you're going to have these chronic inflammatory processes. And there are many diseases of aging, from cardiovascular disease to cancer, many others, that are exacerbated by inflammatory forces. So as people live longer and longer in a still immunosuppressed state, not as bad as the pre-treatment era, of course, they are going to have advanced risk for a number of conditions. So I've worked in the HIV-HPV area. I actually worked on that way back in the 1980s, and I've been doing it ever since. And you have tremendous knowledge now of HPV virology and carcinogenicity, even at the molecular level, that we didn't know 30 years ago. And we know a lot about cervix cancer epidemiology, how the clinical setting can include screening, how this can be expanded globally, and all the health services research and disparities challenge that face us. Now, just a note about my country, the United States. Persons who get cervical cancer, we have over 6,000 cases a year, are much less likely to have ever been screened. This includes racial and ethnic minorities, persons of lower socioeconomic status, foreign-born individuals, and persons who don't have a usual source of healthcare. This is one study from Kaiser Permanente, which is a very well-run health system in Northern California, which reduces barriers to access. Because if you're a member of Kaiser Permanente, your care is free. And they had cervical cancer cases, 833 of them. And more than half of them were a failure screen, had not had a pap smear at all. And 32% of the cancers had had a failure in detection for the first pap smear. It was read as within normal limits, but it was not actually truly within normal limits. There were precancerous cells, but they were missed. And the third is failure to follow. So even with a positive or abnormal pap smear, 13% of the later cancers were not followed up, despite the abnormal pap smear. So this is a classic story where implementation science is essential. How can you have 833 women with cancer in Kaiser Permanente, one of the best preventive medicine-oriented clinical services we have in the United States? This is why. These are the failures of the system. And you can sort of have the Swiss cheese model here, where women may not come in for screening. Healthcare providers may not screen them even though the women are there and should be screened. Maybe there's an abnormal screen, but you don't go to colposcopy or some other diagnostic approach. The patient may not get treated properly and the patient gets cervical cancer. So we want to make these holes in the Swiss cheese as small as possible. Now that's where cervical cancer is extant around the world. Sub-Saharan Africa, the nation of India, and selected countries in Latin America that are the most afflicted. You can see Malaysia is not devoid of cervical cancer by any means. So we have failures. Now these data are old, but to be honest, they lag by about 6 years from when they're good. I probably should have updated the slide. I suspect it won't look much different. Now this was a top 10, and both countries where I was working were on the top 10 of cervical cancer rates, both Zambia and Mozambique, and all of the countries were in sub-Saharan Africa. So you can almost completely prevent cervical cancer by screening, and preferably HPV vaccine being offered. HPV testing is now available, pap smears, of course, and a tool that we use extensively, visual inspection with acetic acid. So we know what to do in a clinic, but how do we bring a program to scale in real-world settings? That was the problem facing us. So we did a study a long time ago, simplest possible study. We did HPV testing and pap smears in 150 sequential HIV-infected women who were coming to our clinic in Zambia. Virtually all the women agreed to the pap smear and the HPV testing. And this was shocking. More than half of them already had cancer cells or had high-grade squamous intraepithelial lesions. More than half. And a paltry 23% had normal pap smear or atypical cells of undetermined significance, which is not very serious. But this really reinforced data that we had from New York City, which and elsewhere, which said that HIV-infected women, being partially immunosuppressed, are at higher risk of HPV-mediated cervical disease. But you have limited financial resources. We didn't have cytotechnologists. Pathologists were very rare. We had low coverage, lost to follow-up, lack of community awareness of preventive care, because everything is curative. You go to the clinic in rural Zambia or even urban Zambia, you go because you have a problem. You don't go for preventive care. That's just not part of the tradition at that time. You might be inconvenienced by going. Nobody likes a pap smear. Embarrassed, fear, stigma, financial barriers, and you need multiple visits. And there are competing public health priorities, so the ministry may not be enormously enthusiastic. But we use this visual inspection with acetic acid to overcome some of these barriers. You paint vinegar, basically 5% acetic acid, wait for a minute, and use a very good light source to visualize. And we also used cervicography. We took a photograph with a high-resolution camera, and that immediately popped up, and you could see the screen on the nurse's screen. So it was like a poor man's colposcopy. Instead of the complexity of colposcopy, we just needed to teach them to take a picture. And then it blew up, and because it was a very high pixel, they saw the cervix, which ordinarily is this big, they saw it this big. And so we had Friday afternoon training every day throughout the whole program. And I would say these nurses had a skill set for detecting cervical cancer superior to any doctor I've ever known at the end of a year or two of working this year. We also looked at how well VIA did. Keep pressing the, there it is. How well VIA did against cytology with different cutoffs. And with our trained nurses, this study was from India, where we were also doing work. With our trained nurses, they were doing as well as or better than cytology. But you'll read the literature about VIA, it doesn't look so good. That's because they aren't as well trained. So if you have VIA, and people are not doing it right, it doesn't do as well cytology. So that's another example in literature, and I accidentally hit this, so I no longer know. I no longer know how much time. I think I've got 4 minutes. Okay, so let me wrap up. We started this cervical cancer prevention program in Zambia, which was a partnership with the hospital, thank you, the hospital, our program, the NGO that I established, and a number of universities. I think you all know this, so I'm going to skip it, but that's all it takes. Vinegar, the swabs, it couldn't be simpler. Camera. And the nurses were the backbone of the program. The two leaders of the program were next slide, Rose Beckaram in the upper left, who started his career as the bodyguard for Jimi Hendrix before he went to medical school and became a gynecologic oncologist, and he was an activist in the Southern Civil Rights Movement. And then his Zambian counterpart, Dr. Malindi Mwanawuntu, in the upper right. And if you're interested, we've published a lot about this. This was our sort of review article that Malindi spearheaded. We did a lot of health fairs. We used health cards as a value document. You see the women holding their health cards up. It was seen as a very positive thing that they got a public exam. Most of them didn't know what a public exam was. They never had one before. It's completely new. Once they understood why it was important, we had a lot of people who would come to our health fair. We also interested the George W. Bush Institute, the Komen Global Alliance, Susan G. Komen for the Cure, which focuses on breast cancer, and UNAIDS, and made this launch in 2011, where you have Rose Beckaram, my colleague, with Tony Fauci, Ambassador Gooseby, who was heading that part at the time, a prominent African women's health leader, and the model. So we've now got this sort of mainstream into high priority for these major organizations. So we've learned a lot about piggybacking these chronic disease programs on top of the infrastructure that we already have for HIV. Why not take advantage of these tremendous investments that have created these programs that actually enabled you to follow patients over time, which was not a tradition in Africa, that anybody got an appointment when they left the clinic. It was all acute care. And now there is this tradition. Why not screen for hypertension? Why not do so much more that we can do, make sure that tuberculosis is handled? Task shifting has worked very successfully. Telemedicine is feasible in some circumstances, especially for assistance in diagnostics. Peer-to-peer support systems, and building capacity for cancer treatment. Fortunately, the first lady of Zambia was an OBGYN, was the chair of OBGYN at the University of Zambia School of Medicine. Her husband became president, and she took women's cancers as her primary priority and helped build capacity to actually care for cancers once they were diagnosed. So lives can be saved with sustained efforts at modest cost, but we do need vaccines to turn off the tap. This is to remind you of the tap. If you leave the spigot of your full bathtub flowing, you'll overflow. So you have to turn the tap off. Then you can start emptying the water, right? So vaccines, I think of as a way to turn the tap off. We also need to pay attention to this work that we did, which showed all of the oncogenic types were far more diverse than they are in the West, in Africa. And polyvalent vaccines are almost certainly the way to go in an African setting. But ironically, the vaccines used in Africa are often the quadrivalent, and we're using the nonavalent, the 9-valent in the US, and they need the nonavalent. They need the more expensive complex vaccine. And I'll just skip this slide and say that's where we were screening in 2006. That's Lusaka, the little green dot. This is where we were in 2017. Next slide. All the green is being covered. The blue was in progress, and only the red was to be serviced. And since then, 2022, we've gotten to all of the districts of the country. We've also used our training site to train people from a dozen countries. We've had people from Pakistan, China, at least 10 African countries come for training on this very user-friendly, low-cost strategy. Now, I'll end by saying, we had regular meetings with ministries of education and health, media orientation for journalists, social mobilization, community and individual engagement, and considering all the gender and equity considerations, trying to make sure that we did as well for rural as urban, we did as well for out of school as in school, that sort of thing. And now COVID, so this is an abrupt shift to attitudes of American parents towards COVID vaccine for children, now that it's available. And you see under 5s, only 1 in 5 parents intends to vaccinate their children. And for 5 to 12s, only 2 in 5 intend to vaccinate their children. And you can see that the hardcore anti-vax folks in the dark green haven't changed much in the span of a year. So community engagement is not unique to some of the poorest countries in the world. We need it in the richest country in the world because we are losing the battle of community education and community engagement. So thank you for your attention. Tremendous challenge to communicate health and science to lay audiences, policymakers, for all these and many other reasons. We're all going to have to get better at communicating to broad audiences because there are many anti-science voices out there now that are confusing people. So we'll have to raise the level of our game. Thank you for your attention. All right, I think we have a few minutes for Q&A. Just come up to the microphone if you have a question and or a comment, and I'm happy to engage. If I know the answer, if not, Luke Davis will answer. By the way, if you like that talk, my name is Sten Vermund. But if you didn't like the talk, my name is Luke Davis.
Hi, everyone. Sten, you know, I'm always impressed with the way that you sort of bring the history of all of this work to bear. And as you were bringing out things, I was sort of thinking, okay, what is the implementation science word that we would use for many of these things? And, you know, as it turns out, those of us who are doing global health have really been doing implementation no matter how you slice it. I'm just wondering, you know, your sort of examples on implementation work in high-income countries, the US, which had a number of similarities to very low-income countries as well. But I'm wondering if you have any thoughts around how some of these things may apply in middle-income countries where they're sort of striving for those ideals. with medicine and professionalism and things like that, where let's say task shifting and stuff like that is less on the radar screen, and how you might think about that somewhat different, because most of your examples were, I know you've worked in China, but are from the extremes. I wonder if you have some thoughts about that.
That's a great point. I think that middle-income countries, and Malaysia is a great example, have the potential to be especially innovative because we don't have a very coherent health system in the United States. Our health system is really a concatenation of historical accidents. We have Medicaid for poor people, we have Medicare for old people, we have insurance for working people, we have the VA is socialized medicine for veterans, we have the Indian Health Service, but only certain Native Americans can use it, not others. And it's just a patchwork quilt with a lot of people falling through the cracks. And in Malaysia, you have a much more coherent system. So the prospects of actually achieving some of these information goals in terms of full screening and full follow-up of screening results, these are things that are realistic. And you could be global examples, I think, or you are global examples, I think, for some of your programs and could do even more. So be ambitious. Don't take what we're doing in the US as some kind of model, because we don't have a very good model in the US. I think they're doing much better in Great Britain, for example, where they do have a coherent health system, and the integration of curative care and preventive care is much more coherent than it is in the US. You know, our public health system in the US is funded completely apart from our health system. So if you achieve savings in the health system through public health interventions, those savings don't accrue back to the public health system. There's no feedback loop. So there could be incentives and systems established in a middle-income country that has a coherent health system that could be surprisingly effective and successful. Because you still have challenges with HIV, you have challenges with cervical cancer, you certainly have challenges in integration of health services to make sure that folks with chronic infections also have access to proper screening for big killers, including hypertension, diabetes, and the like. So I think some of the research questions would be the same, but your ambition could be even greater. That would be just one part.
Thank you, Sten, for a wonderful talk. I could listen to you and your experiences much longer. I was hoping that you could tell us just a little bit more about how you were able to work with your colleagues to scale up from, you showed us the map where that initial district where you were and how it was able to spread across the country. And was that a policy shift? How were you able to do that and what it was involved?
Well, as Professor Adeeba knows and Professor Rick, it's not easy because you are constantly struggling for resources. Our very first grants for PMTCT in Zambia were from the Pediatric AIDS Foundation, which later was renamed to be the Elizabeth Glaser Pediatric AIDS Foundation. And that was a lot of money that mostly came from Hollywood celebrities that came into a foundation. And that got us going. Then there was an initiative that was spearheaded by the late Alan Rosenfield and by Wath Al-Sadr at Columbia University. They had a consortium of 5 different foundations that threw into the same pot. And it was built on a paper that they had written, where is the M in PMTCT? Where's the mother part? You're treating the mother to prevent the baby. What about caring for the mother? What about caring for the father? What about caring for the siblings? What about the more? And we had started with very modest resources, a model HIV clinic for the entire family. But with these resources from this foundation, we were able to expand that into multiple clinics, and that was the sort of pre-PEPFAR learning curve. So then PEPFAR came along in 2004, and we were one of the first partners, the so-called 1.0 partners, we threw in with the Elizabeth Lytopia, AIDS Foundation, when they wrote a multi-country grant, we handled Zambia. And then we had substantial resources. And we were able to expand our program quite rapidly, including care for adults and families, because we had this experience. So you may have great ambition, and you may have to start small. But if fortune smiles and the field catches up with your vision, there may be resources that you're poised to take advantage of before anyone else, because you've done all the preliminary work to make clear what you intend to do and how you intend to do it. So that was what happened. The cervical cancer was more difficult because PEPFAR was not keen for any money to be used for anything other than HIV treatment. They let some of the money go for TB treatment, but you had to be HIV co-infected, which is ridiculous. How can you not treat all your tuberculosis patients? Who cares if they're HIV infected? So there were some programmatic limitations that were designed to force people to be 100% focused on HIV. Well, I didn't want my women in my program to die of cervical cancer. You know, it's like the old adage with the surgeon. Surgery is a success, but the patient died. Well, the ART is working, but the patient died of cervical cancer. So we had some bitter disputes. I had a US government official hurl a pencil across the room at one of my colleagues just for our being persistent in advocating for cervical cancer prevention. We had the same problem with malaria prevention in rural Mozambique. It's a highly malarious part of Mozambique. And all we wanted to do was a tiny, tiny budget for bed nets and malaria education. They wouldn't let us do it. And we pushed back, pushed back, pushed back. Let me just say, we ended up getting cervical cancer money, we ended up getting bed nets, and we ended up influencing the whole PEPFAR program because I let the leadership of PEPFAR know that this was going on, and they said, this is not correct. You're doing HIV care, and you're helping protect people so they don't die of malaria, they don't die of cervical cancer while we're saving their lives with ART. So it does take some guts to do this work because you have to speak truth to power.
Thanks, Sten. I'm aware that we need to move on, but if you will indulge me. Thanks for that inspiring walk through the history of implementation science in HIV. My question is, and I'm currently particularly interested in cervical cancer because we're working with colleague Wu Yinling, hope to sit down with you and really pick your brains on this. But your examples of the improvement in clinics seems really doable, but the cervical cancer program, and we know this right now, can be really daunting. I guess that's why we're here over the next 3 days to be taught how to implement programs in a systematic manner. But if you were to tell us, right, to have these ambitious programs, you're talking about community awareness, training nurses and media training and looking for funds, where would you start? I mean, it can be so daunting and overwhelming.
How vibrant and vigorous are your women's organizations in Malaysia?
They are, actually.
That might be a first step. Because if you can gain allies from pre-existing politically powerful groups and influential groups, that may be exactly the first step. And see if you can broaden the strength of your numbers and your influence with some of these pre-existing folks who are likely to be tremendous allies when they learn what you're trying to do. And I also wonder about how implementation science might help you mainstream cervical cancer screening and perhaps vaccination in adolescents, those two as priorities, and have that be an utterly routine part of a woman's visit to a clinic. That if a woman hasn't had a pap smear in X time, then that's part of her care, no matter what she comes for.
You're actually moving to HPV screening.
Yes, if you have the resources, you could do that. The tricky part about HPV screening is you treat every HIV positive person. But if you use it in an algorithm where HPV identifies the people who need further follow-up, then it might be very cost efficient for you. And but it's hard to justify treating women for HPV when they don't have lesions. You'll be treating a heck of a lot of women because HPV usually self-limits with no substantial consequences. So people who may have an oncogenic strain of HPV, if you do nothing, many of them will regress, and you won't be able to detect that a few months later. So you don't want to necessarily aggressively treat every single HPV positive woman because you're not taking advantage of the body's immune system, which is going to clear a lot of those infections. So I think having an algorithm, and the literature is replete with recommendations for how to deploy these, and I think you may be able to come up with an efficient strategy. But how to engage women, perhaps women from conservative religious backgrounds whose husbands don't understand what this is about. I think those are the sorts of things that an alliance with community-based organizations might be immensely helpful. But you probably already have such alliances and you're just testing them. But I'd be happy to talk to you about this. We have a lot of experience from very different ecosystem, but still it might be relevant. All right, thanks very much. Now, some figuring and erudition.
Thanks very much. Next up we have Luke Davis, who's a pulmonary critical care physician and epidemiologist using translational research, implementation science to improve diagnostic evaluation and case finding for tuberculosis. He's an associate professor of epidemiology of microbial diseases and of medicine, pulmonary medicine. Dr. Davis teaches a graduate course on implementation science and mentors students at Yale School of Public Health and enjoys mentoring medical students, residents, and fellows. The title of his talk is Implementation Research from Basics to Advanced, Terminology, Frameworks, and Theories to Guide the Process.
Good morning. It's a great pleasure to be here today, and I want to thank Iskandar for that nice invitation, Professor Adeeba for the welcome here to Malaysia, and to everybody who's made this comment. As you heard, I'm an associate professor in epidemiology, microbial diseases, and I have a little interest in implementation science. A number of you here today had the chance of taking my course, and I hope others in the future might be able to take it remotely. But I'll be talking for about 35 minutes or so about theories, models, and frameworks. But before I do that, I also want to introduce you a little bit to some of the unique terminology of implementation science. And this is a word cloud that I created from the opening chapter of the Dissemination of Implementation Research in Health textbook. Of all the words there, the most frequent. And you can see that there's a lot of words there that we may know and may have meanings within epidemiology, but within implementation science, sometimes they're a little bit unfamiliar. But what I want to try to explain to you today is that implementation research, for all its uniqueness and all its methods, is really just familiar concepts in an unfamiliar package. And our goal here today is to try to demystify that by grounding you in some concepts that I think you're aware of from your prior training or from your everyday practice, and help you understand how they apply so that you can use this language to speak to each other and to design programs that will help us translate evidence into practice. So you can see that interventions or programs in this diagram are trying to achieve a certain health outcome. And to do that, we have to consider in epidemiologic terms, what are the mediators, what are the pathways, what are the mechanisms that we create that change, and also what is the context, what are the factors that may change that. And we often consider barriers or facilitators. That's a common implementation science term, which are things that might help impede or also help promote delivery of that evidence-based intervention. We have implementation strategies, which are things that we do to get people to change their behavior or change their practice to deliver these evidence-based interventions. We have implementation outcomes, which are moderators within the implementation science area. We can think about these as factors, ways of delivering our interventions. And then we'll also talk about these terms of fidelity and context as two of the most important implementation science outcomes. Fidelity referring to whether we've delivered our intervention the way it was meant to be delivered, or whether we've adapted it and how it's operating in the environment. And then the context, of course, being very important about the people, the places, the plans, the players, the environment to deliver that. And then ultimately, we use theories, models, and frameworks to help us guide the process. And we'll talk more about all these topics today. So our roadmap is to first give you an introduction to the key implementation science research terminology and concepts, give an overview of theory, models, and frameworks in IR, and have some time for questions, which I hope you'll break down and you can come up as we're going along and bring them up at the end. So first, an introduction to the key implementation research terminology and concepts. So implementation science, and there are many, many different definitions, but this is one that I've come up with for myself, is a systematic approach. And we say systematic because it is a science. There's a methodology to it, there's a way that we go about it. For the design, so that's planning, the delivery, that's the actual implementation, and the evaluation, seeing how well we've done at the end of all that, of strategies to promote the uptake, adaptation, and maintenance of evidence-based practices in routine settings. And for our purposes today, when we talk about evidence, I think that's a whole lecture in itself, we want to pick things in which there's studies, well-done studies in the literature that show us that those interventions or practices work, or they could be empirically supported treatments that there's wide consensus within a Ministry of Health or within a community of practitioners that these services should be delivered to improve health outcomes. So I want to give you a few characteristics of implementation science. This is a flavor for understanding what are the things that make it unique. And one thing is that it's a translational science. This is a diagram that comes from a National Institutes of Health document starting to think about how do we move ideas from their nascent development into routine practice. And we think about the terminology of translational research having different stages. At its most basic, we think about starting at the bench in the laboratory, but in human population health, sometimes we think about the theories of how we would deliver care. We want to move those from to the bedside for sick patients, to the community for people who are well in terms of preventive services, and ultimately scale those up to all practices. And the early stage translational research is typically the label that we think about for translational research. But I want to argue to you today that implementation science is itself a translational science. It's going to call on multiple disciplines, including a basic science of human behavior and interactions among individuals and organizations to try to deliver these evidence-based practices. And while I've shown this somewhat as a pipeline moving from the beginning to the end, we also know that this is an iterative process of disseminating, implementing, hearing back from practitioners about what works in the real world, and then modifying that to make sure that things can be delivered. So knowledge translation is really our business in implementation science. How do we translate what's in a textbook or a journal to the real world practice? You saw some great photos that Sten showed this morning of rural and low and middle income settings where we have to really change the way that we think about delivering our interventions. So we may want to use education and a lower fidelity method like visual inspection than what's traditionally thought to be more higher technology ways of diagnosing cervical cancer. And in order to do that, we can think about several stages. There's diffusion of knowledge, which is just publishing it and hoping people pick it up. There's dissemination, which is hopefully probably what we're doing today, disseminating new ideas and spreading them to you and giving you ways to access that information for yourself. And then implementation is really the nitty-gritty. How do we actually make these things happen in order to translate evidence into practice? One thing that is quite confusing in implementation science is a lot of times we use the same terminology in different ways in different subgroups. So physicians may talk a certain way, public health folks may talk a different way, social scientists may talk a third way. But all of these concepts are really a bit similar. So in Canada, they talk about knowledge translation. In the United States, we talk about dissemination of implementation science. In the UK, they talk about complex interventions, which are interventions with multiple component parts that work together to help improve population health. And in most of the rest of the world, we often hear the terms operational research or implementation research. And I'll try to use that term implementation research today. But if you hear me say other words, I'm talking about the same discipline that's trying to translate evidence into practice. So for example, knowledge translation, which is a term that's used in Canada, is one that I kind of like because it encompasses a lot of these different aspects. We think about the scientific aspects, which is often more research-based of dissemination and implementation, but we also want to think about how do we use these in everyday practice. And this conceptual map, and you'll have access to my slides afterwards if you want to go back and look at this in more detail. This is a wonderful map that puts all of these different terms on the same page. And I won't go through it in extensive detail today, but I'll just try to point out that we're living here in the health services practice landscape. And within that, there's different neighborhoods. Some of these neighborhoods are interacting or overlapping, and some of them are working independently and hopefully in a complementary fashion in order to achieve the same goals. But within implementation research, which is our focus today, we can think about moving beyond just implementation practice to try to think about how can we frame questions, and we'll talk a little bit about what questions might be relevant in implementation science, and to try to change the knowledge base that we have. Within that, quality improvement, which I think is a commonly used term, is one particular type of implementation research. Another principle of implementation science is that we don't want to have the mechanisms by which interventions are delivered to be living inside a black box. You know, if you think back, I think we've all read studies or learned about approaches in school where they said, they did that study and it didn't work. That approach doesn't work. In my field, the example of that would be going out into the community and trying to do case finding for tuberculosis. There have been a number of large trials that were done that had non-significant p-values at the end or thought not to work. But unfortunately, people many times after that fail to go back and say, was the intervention actually delivered as intended? Did everybody get it? And we know from some of the examples that Sten gave earlier that a lot of times, in spite of people's best efforts, getting 80% of the way there might not be enough in order to achieve a health change that you want to see, that you might have seen maybe in a more controlled experimental type trial. And so if implementation doesn't work, we won't know how or why it didn't work. And if it does work, we won't know how. So I also want to differentiate between the concept of interventions and implementation strategies. So interventions, and this is courtesy of Jeff Curran, who's a wonderful teacher in the field of implementation science. I encourage you to read anything that Jeff has written. And what he talks about is that the intervention, practice, or innovation is the thing that we want to do to improve health, the health outcome, whether that's morbidity, mortality, preventing hospitalizations, preventing the development of a disease like cancer or tuberculosis. And implementation strategies are the stuff that we do to try to help people or places do that thing, to deliver that intervention. So these might be things like education. It might be programs to measure performance and feed that performance back to the practitioner so he or she knows how well she's doing and has an opportunity to improve. It might be enabling functions, such as extending, providing support for practitioners who are overworked so that they can do more. These are all examples of implementation strategies. And we want to package those things together to change the practice of providers or change the behavior of patients in order to enable them to take up and benefit from these evidence-based interventions, these evidence-based practices. So a couple other concepts that I want to get across are fidelity. And And so fidelity is kind of a big word that refers to how well we deliver the intervention that's actually to be delivered. And I love this cartoon. I think this cartoon, it's called the Fidelity Challenge. And what you can see here is that there's a bunch of cakes that are being evaluated. And when you think about cooking, there's two types of ways of cooking. One is if you were making particularly a savory dish, you add a little spice of this, add a little spice of that. Sometimes I ask my mom or my stepfather, how did you make that? They say, I'm not sure, I just did it to taste. And that works fine for a savory dish, but if you try to bake a cake or make cookies and just guess at the ratio of proportions, you will get a very, not very delicious tasting cake. And so there are certain interventions where you have to be very faithful to the recipe. You need to follow it very precisely. And there's other areas where you can play around a little bit. And so I like the idea with a cake. We have to make the cake in a certain way, but once we ice it, we can decorate it in a certain way, and that allows us room for adaptation. So the concepts of fidelity and adaptation will be something we'll get into a little bit more tomorrow when I talk about implementation outcomes. And then the other kind of key implementation outcome that I want to get across is context. Context is a key implementation outcome that relates to how generalizable our findings are. And if we develop a program to deliver HIV services, we know it's going to be quite different if we do it with a certain key population that's located in an urban area that may be dealing with specific types of challenges, whether those are substance use or other things. When we think about how we would deliver it in a rural area where people have to travel long distances to seek care, they may be dealing with stigma more. And so while we might have a common intervention here, what I'm showing you is the intervention of community, a common strategy to deliver, which would be community health workers to help extend the reach of HIV services. It might look very, very different in different settings, and that's what we refer to as context. Okay, so what are the 4 key ingredients in implementation research, just broadly speaking? I want to talk about each of these in the next 4 slides. The first is having good implementation questions. The second is having an implementation research team. The third is having community partners. And the fourth is theories, models, and frameworks. And after introducing that, I'm going to spend most of the rest of the talk going into detail about what I mean by that. So implementation research questions, just as I alluded to in the definition that I gave you at the beginning, can be thought of in 3 general categories. There's formative research, which would be at the beginning of planning. We might want to understand what is the difference between what's happening in routine practice and what we ideally would like to see happening. We also might like to know what is explaining those differences. Those may be factors that exist at the individual level, or they might be at a higher level, such as an organizational or a policy level. Next, once we know what the problems are, we can design and plan the solutions that can then be targeted to address those barriers that we identified in formative stage. One key thing sometimes is just to understand whether a setting is actually ready to begin implementation. I had an experience a few years ago where I wanted to introduce a new diagnostic test for tuberculosis in our hospital in the US. And what I found out was it wasn't a good time to do that because we were in the middle of a huge influenza outbreak. Many of you have been dealing with something similar during the COVID era. You have to wait to the moment where the clinic is ready and able to move forward, and there are many ways in implementation science of actually measuring that. What strategies might be used to help implementation? And then once you've delivered the intervention or introduced it, how well was it delivered, and what factors explain the success or failure of implementation? The second thing is implementation science is a team sport. And I like to think that many of us in this room probably came from a background in population health, whether that's as practitioners, medicine, nursing, pharmacy, or from the population sciences, biostatistics, epidemiology, health policy. And what we really need to do is reach across the aisle, so to speak, to our colleagues in other parts of the other ministries or maybe in other parts of the university to draw on their expertise. We heard a lot about social sciences in Sten's talk. We know that economics is really an important factor, so we may need some experts in that area. And a lot of times engineers can really help us think about changing our processes or our technology. And implementation science, dissemination science exists at the in the intersection of all these. It doesn't require all of them necessarily, but you need to rely on members of the team that can help you answer the question. Another key factor is community partners.
And it's very, very important. I don't think I need to really emphasize this too much to a community of HIV researchers.
Okay, great. Sorry about that. So I'll skip over that slide. The community engagement group, the community engagement aspect is very, very important for understanding what is the community So community engagement will be great, and we'll have a chance, I think, to talk more about that. Last is theories, models, and frameworks. So theories, models, and frameworks help us organize our approach. Given that implementation science has multiple objectives, oftentimes we rely on multiple disciplines. We may need multiple different components in order to achieve this. So you heard earlier, I think what Sten was talking about, sometimes having an educational intervention with a technological intervention. So putting those components together, that also adds a lot of complexity. We may have multiple implementation levels. So we may be working at a primary care clinic, a regional referral hospital, and maybe sometimes in other levels beyond that. And we may have to consider multiple different implementation outcomes, things like fidelity and context. We also want to be able to communicate our plans and our results clearly. We want to be able to explain how and why implementation works and doesn't work. And all of these are aspects that theories, models, and frameworks can help us. So now we'll move into a more in-depth discussion of how we can use these in implementation research. So here is a taxonomy of theories, models, and frameworks in implementation science. We're going to use the rest of our time together to go through these different levels and try to understand things. And this is a bit of a complex topic. One of the challenges with this is that people use a lot of times, they don't necessarily follow the rules that I'm going to share with you today. And this is a wonderful article from Nielsen from Implementation Science that I'd be happy to share. It talks about the different types of, we'll call them theoretical or framework-based approaches to address, to advance implementation science. And at the far left-hand side of the slide, you can see that describing the process of translating research into practice is the role of a process model. And I'll talk a little bit about process models and a couple of other types of models. Second, we have understanding or explaining what are the factors that may influence implementation outcomes here in the middle. And in that regard, we have three general categories. We have determinant frameworks, we have classic theories, and we have implementation theories. And then finally, on the far right-hand side are evaluating implementation and evaluation frameworks. I think what you're going to find is that process models and evaluation frameworks are very easy to understand and quite straightforward. Consistently, when I talk with students, they like that and understand that. The middle part is the more challenging part, but I'm going to challenge you here to try to say that if you can understand these frameworks and try to adapt them for their use, they can be very powerful tools. So we'll start first with definitions of models, theories, and frameworks. So the first is a model, and a model is a deliberate simplification of a phenomenon. You can hit the next button, please. Deliberate simplification of a phenomenon is descriptive only. And I'll go into a little bit more detail in a moment. Second, we have theory, which is a set of analytical principles or statements which help structure our observations, understandings, and explanations of the world. Theories are descriptive in the same way that models are, but they also want to try to predict or help explain how things work. And the way I like to think about it is, with many other aspects of medicine or public health, we may know something about the basic biology of how an agent works. For antiretroviral therapy, we know there are different mechanisms that may target different phases of the HIV life cycle. With behavioral science, a lot of times we don't have that level of precision, but what theories are trying to do is give us some way of thinking about that and testing that in the real world. And then last, we'll talk about frameworks, which are structures, overviews, outlines, systems, or plans consisting of just deliberate categories that help us characterize phenomena. They're descriptive only. We can think of these as checklists and ways of organizing our findings for communication or for planning. So first is models, and I love this little cartoon. You can see this cat is trying to make a plan of how to get the ball up and out the table. Cats are very clever, and they form plans sometimes, and they don't always do what you're expecting. But the idea of having an overall way of explaining your thinking about the world to the people that you're working with is incredibly valuable. Whether that's just a simple process map, like Sten described earlier, sitting down in the clinic and getting people to stand up with Post-it notes or on a whiteboard or a chalkboard and describe to you how people move through a clinic or how people were thinking about what the problems are. That's a conceptual model, and there are really no restrictions on how you create these. What I want you to try to think about today is how do you move from that to try to make that into something that is more generalizable and may allow you to benefit from findings that have been used or frameworks that have been used in other settings or to communicate what you're doing to other people. Second is process models, which are ways of going about implementation science, and the last are logic models, which are another way of describing how you're doing your work. So here's our process model that was put together by Binti and colleagues who developed the behavior change wheel based at the University College London. And this process model is one we use in our course to help students design an intervention. And we want to start out, we often start out by defining the gap between evidence and practice. Then we specify, in order to deliver a certain type of service, if it's diagnosis of tuberculosis, we need to screen people, we need to do testing and evaluation. If they're positive, we need to start them on treatment. If they're, once they start treatment, we need to make sure they finish treatment and that they're cured. Each of those is an individual behavior that we want to try to understand. What are the barriers to actually delivering that? Next, we try to identify the determinants of adoption or adherence at each stage of those practices. And then we design a targeted strategy that would address each of those barriers, and then we implement and evaluate. So this is a process model for delivering an intervention, and it's a generalizable one. Another type of model that can be used is a logic model. And logic models are very popular with funders because they're a way of ensuring accountability for the resources that they've granted you. And the idea is that you're going to tell the funder what types of resources you need to operate your program and inputs. What activities are you going to do once you get those resources? What are the intermediate stage outputs that will come about? As a result of those outputs, what types of outcomes can we try to see that might be surrogate markers ultimately of some public health impact? This is a very classic form of a logic model. And here's an example from a project that we did to implement testing in our hospital in the US. And you can see that there's a lot of detail here. It's not very conducive to presenting in a lecture hall. So I think logic models better go with reports to help people really dig down and understand what you're trying to do. But they're often very logistical and they can be really useful for project management. Next, I'd like to try to get into talking about theory. So theory is a systematic way of understanding events or situations. And it helps explain or predict events by illustrating and ideally testing the relationship among the variables. Theories, unlike models, which are very specific to a certain situation, should apply to a broad variety of situations. They're abstract and not confined to specific content. Now, as someone who did not train in behavioral science, this idea of theory took a while for me to get used to. And this was a wonderful primer developed by the National Cancer Institute that gives some very basic descriptions of different types of classic theories and some implementation theories. And I think you'll be surprised today. I know some of you probably use theories in your work, and others, I think who theory is new to you, you'll be surprised to see that you have actually heard of some of these. Next slide. So why use theory? Theory may help us design interventions that are more effective than those that lack a theoretical basis. And that kind of makes sense to me. If we are just doing things with some guess about how the world works versus designing them to target certain barriers, theory may be very, very helpful. Making research more theory-based may help improve evidence-based practice, and good theory is what enables knowledge to emerge out of seeming chaos and be translated into effective use. There's a couple of different types of theories, classically speaking, and again, this comes from this wonderful National Cancer Institute primer on the use of theory. Generally speaking, we have explanatory theories that kind of help us understand what can be changed and why does a problem exist. Versus, on the other end, change theories. How can we actually change that situation? What strategies, what messages might we use? And how can we challenge assumptions about how a program should work and actually implement them to address this problem, behavior, or situation? As I said, in the field, there are often maybe inconsistencies. And I've included here the term classic theory, which is the term that Nielsen used in that initial diagram that I mentioned, which is really just an explanatory theory. And we're going to give 3 examples, or maybe 2 examples of classic theories to help you understand what we mean. And then implementation theories, I think, are the ones that you'll really like because they're powerful tools to help you figure out how to design strategies and address. So what is the purpose of theory? Well, as we said, explanatory theory wants to help us understand. So in the situation of smoking, let's just say you're designing an occupational program to decrease smoking, to have health benefits in your population, and potentially to reduce the resources that are dedicated to caring for people in your organization who smoke. So understanding why employees smoke might benefit from the use of classic theories such as the health belief model, which I won't go into today for time, but really relates to people's understanding of the balance between their perceived susceptibility to perceived resources and the risks and benefits of taking an intervention like quitting smoking. Second, theories of change, which help us understand how to get employees to quit smoking, can also be very, very powerful. And a good example of that is the classic trans-theoretical model, which I'll show you in a couple slides, which thinks about change. So the theory of planned behavior is another explanatory theory, a little bit like the health belief model, one of the most widely used theories. And I like it because I think it applies equally well to patients and also to providers, which are two of the groups that are most important when we think about implementation science. And the key premise of the theory of planned behavior is that intention is the key determinant of behavior. And I know this is a bit small, but I love using the original diagram that appeared in the Einstein paper. What it says is that our attitudes, subjective norms, and our perceived control of our own behaviors are really three of the factors that govern our intention to carry out a behavior. And often that behavior would be a health positive behavior that we want to carry out, or maybe it's a health negative failure that we want to downregulate. And by doing that, by understanding this type of model, we can make measurements to understand where do we need to intervene to actually change the way people So an example of the theory of planned behavior was used in a study that we wanted to do to try to improve the quality of tuberculosis. Well, I guess I changed this a little bit example to maybe be more relevant to the smoking example, which is that smoking is a big risk factor for cancer and tuberculosis. And so we really would like to get people to be able to quit. And to do that, we're going to, as providers, prescribe to them a recommendation that they quit smoking. And we want them to start to quit and then maintaining quitting. And in order to do that, we may have to address the key attitudes, social norms, and self-efficacy. And so these are some quotations from qualitative work, but this is an imaginary study that I made up. But you can imagine interviewing a group of smokers who tell you, I'm still young, I can always quit later when I'm ready. My friends and family all smoke, or I can't quit, I've tried before and failed. So each of those may be targets that you can intervene upon to improve care. We've used similar models to change the behavior of health workers. Another way of looking at this is that the change is actually not a single event that happens or a single theory, but it's a process that happens over time. And the trans-theoretical model is one of the most widely used theories, especially for addiction behaviors. And the idea is that smokers, for example, we can go to the next slide and see this, we start out in a pre-contemplative phase, where I'm not aware of my smoking as a problem and I have no intention to quit. But then eventually that kind of changes. Maybe they become more aware of their surroundings or they have their own health needs. And they're saying, well, I wonder if I should move forward to quit. And then preparation to quit. When might I set a quit date? What would I need to be successful in quitting? And then when I actually go about the action of quitting, I'm adopting new habits, and what can we do at that stage to help support people through a combination of interventions and strategies. And then how do we maintain that over a long period of time? So the trans-theoretical model, very powerful approach. It does not necessarily fit all types of behaviors. It's not a particularly good one, say, for changing health worker behavior, but it's really good for patients in certain types of situations. So now we've talked about classic theories. We've talked about implementation theory. Now we're going to talk about frameworks. And remember what we said with frameworks is frameworks maybe sometimes incorporate theory, but generally they're not theoretical. They're all about trying to have a systematic approach for measuring. And this theory of means framework is one that combines theories and frameworks. And its approach is that change requires identifying and classifying the factors that determine relevant individual behaviors. And this one was developed in a very interesting way. A group of sociologists, psychologists, and public health practitioners got together and they reviewed all the known theories. I think they found more than 83 theories, if I can remember correctly. And they tried to say, what are the core components of all these theories, and how can we standardize them so that we can all be speaking the same language? Their goal was to help advance implementation science by providing a common framework, the theoretical basis for designing interventions. And this is a very powerful one. I've used it many times. And generally speaking, there are 14 different categories, but there are 3 general areas, which are knowledge and skills, sources of motivation, and social environmental influences. And some of the students who've taken my class have also found it powerful as a way of categorizing the barriers and then using those barriers to design interventions that would target. So if we have a knowledge problem and educational interventions appropriate, but what I find many times in circumstances, particularly in resource constrained settings, is that the knowledge is there. It really is other factors like lack of resources or demotivation, chronic demotivation from lacking resources over time. And so you come up with a different set of factors to implement. Another type of framework, again, a determinant framework that's going to help us identify the factors in the environment that prevent implementation. It's called the Consolidated Framework for Implementation Research, or CERiA. This is one of the most widely used frameworks in implementation science. And its premise is that implementation requires adaptation of the intervention. You can see on the left-hand side this lovely clip art. They're showing the core components of an intervention that's unadapted, and you can see it's kind of a clumsy fit to a clinic setting, which would be the inner setting, to the people involved, which would be the practitioners, maybe even to the outer setting, which is the Ministry of Health or the funding environment that's going to create the resources to deliver this service. And CERiA is a framework which consists of these 5 domains and then multiple subdomains would allow us to go through systematically, and either through qualitative inquiry or sometimes through surveys, identify what are those factors that are preventing this setting from being ready, and then hopefully adapt that intervention so it fits better to the framework. So here's an example of using CERiA to assess the readiness for implementation. This is a study that was done by a couple of our trainees in planning for contact investigation for tuberculosis. And what they wanted to do is go to these 32 clinics in Uganda and see which ones might actually be ready. And to do that, they used the consolidated framework, and they also used a checklist that was looking at key supplies and resources that would be necessary. And they categorized these into these different categories, their constructs. And you can see they're categorized into factors that exist related to the inner setting, the outer setting, etc. And then how frequently are those present? And so this can provide, it doesn't give you an answer of whether a setting is ready or not ready, but it helps you understand what areas might you need to intervene upon and how might you want to intervene upon them to create change. So the last framework that we're going to talk about today, and I'm just giving you a couple of examples that are commonly used. We'll have a chance in the session tomorrow afternoon to talk about how do we choose among these different frameworks, and potentially we could talk about other frameworks that I haven't talked about today. But I'm telling you about some of my favorites. It is REAIM. So REAIM is a framework that stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. REAIM is a strategy or a framework that says, operates on the premise that evaluation must first consider multiple steps in a cascade of activities or services. We saw a lot of cascades in Sten's talk. They really transformed the way we think about HIV implementation science. And here you can see a cascade thinking about the multiple stages. So are we going to get providers or a certain clinic or a certain region to adopt a new intervention? Can we reach the people that actually need it? Let's just take something like PrEP. Those are 2 of the key steps that we would have to get to. Can we deliver it effectively? And that might include not just giving someone a prescription, but also making sure that they pick up the agent and they take it on a regular basis and they don't drop out over time. So these are some of the implementation concerns, making sure that those drugs are present in the pharmacy. And then how does the program get sustained over time? Maybe beyond just the initial set of research funding, how do we make sure it becomes endemic? And each of these steps of REAIM can be assessed quantitatively, they can be assessed qualitatively to understand the delivery of that intervention. And I don't really need to go into this. You've seen a number of examples in Sten's talks, but again, the REAIM is a great way of generalizing the general function of a cascade to understand delivery of services. So the last, actually, I didn't tell you, there's one other framework that I had to mention, which is Proctor's Implementation Outcomes Framework. And this is actually not new in this talk. At the very beginning slide, I showed you this picture of this black box. It was covering up the center of this slide, and now I'm revealing what's behind it. And remember we talked about evidence-based interventions and saying that we need strategies in order to deliver them. The what is the evidence-based interventions, that strategy to the how. And then implementation outcomes tell us how well were those strategies actually delivered. In my talk tomorrow, we'll go into more detail about what are the specific implementation outcomes that we want to look at. And that will help us understand how well the intervention was actually delivered and what were the ultimate health impacts. So I also said that we'd be talking tomorrow about how to choose a framework, but I don't want to leave you to wait till tomorrow. I want to give you some initial thoughts. And it's very important when you choose a theory, model, framework to have a rationale for why you choose it. It's sometimes difficult when you're new to a field, but it may be good to choose one that's familiar to you or someone on your team. And it's also good if that framework is a framework that is able to be understood by your audience. So if your audience are a group of public health policymakers, you may want it to be a very practical framework that's implementable. And maybe some of the ones that are more technical or behavioral may be less useful. If on the other hand, you're working with a group of psychologists, it may be more helpful to kind of use a classic behavioral theory that they may be familiar with. Another challenge that we have in the field is that people may use theories or frameworks, but use them superficially. And unfortunately, that probably isn't the right way to go either. You want to try to use something so you can benefit from it. And also, an important goal of implementation science is that what we learn, whether a framework, theory, model works well or doesn't work well, we can convey that to others in the field to help move the field forward. Because often what we learn from, say, implementing prevention for maternal to child transmission may come back later and help us improve cervical cancer screening, to use it, again, some good examples that Sten talked about earlier. I want to conclude by saying, don't be intimidated by theoretical approaches. Really, theory and practice are intertwined, and they're the trunk, the basis for learning, which is the kind of the flowering of those initial efforts that you do in planning implementation. And a couple of very famous quotes, the philosopher Immanuel Kant: "Experience without theory is blind, but theory without experience is mere intellectual play." And then a little bit more down to earth, "There's nothing so practical as a good theory because it gives you a plan or a roadmap for moving forward." So with that, we'll stop and hopefully have a little questions, showing you a little picture of the New Haven campus in the summertime, where we have some nice green trees and some sunshine. But it's my pleasure to be with you here today. So thank you. Thank you so much.
Thank you very much for that very interesting talk. So I work in Universiti Malaya and I'm an ID physician and I run the infection control program. So it's more hospital based, and I think a lot of the things that you had showed here is very, I think, pertaining to the challenges that we face in the hospital. Something as simple as hand hygiene, we kind of implemented, and I think it's time for us to move towards implementation science, and I think a big component of that is behavioral. So my question to you is, I mean, it looks very complex, but how long does this whole process take? Let's say if I want to change or improve hand hygiene in my hospital from the start of the framework and conceptualization, how long would the shortest minimum period to the norm in a practical manner?
Right, I think it's a great question, and I think there could be an inherent criticism in that, which I would accept, which sometimes when we make things so complicated, they do take longer. I like to try to think that sometimes by having a better basis, involving more people, and explaining your mental model, that extra work that you may put in up front may really pay off down the road in stronger partnerships. That's really, I think, probably one of the key messages, is something as complex as changing the infection control practices in a hospital, where you're working with lots of people with different backgrounds, right? You have nurses who are trained in a certain way, you have doctors that are trained in a different way. You have infection control providers who are thinking very broadly, not about the individual patient. By getting them on the same page, a lot of times it helps expose what some of the challenges are. But I think, depending on what your goals are, you can modify the choices to be more practical. So a theory like re-aim is just probably something that they could quite be easily explained and really help you understand, particularly when you translate each of those levels to specific indicators that you can measure and understand where you're falling down, and that can make a difference. I'd be happy to share, one of the frameworks that I talked about, the theory domains framework, was used quite successfully in an infection control program in the UK, in the National Health System there, to improve worker hygiene. And they identified sort of certain factors, some knowledge factors, a lot of motivation factors, and they were able to design a multi-component implementation within about, I think it was about 18 months. They were actually able to get going, and once they got going, they were really able to take off. So, thank you for the question.
Thank you very much.
Hi, thanks for the talk. I'm Binti, and I'm a psychologist working in the IT community. So my plan is actually to implement a mental health screening program in the clinic itself, and I'm doing formative work, collecting the determinants that might possibly impact the program. But now I have questions on how do we pick which determinants that we should focus on in our program. Because from a lot of the literature, there's no clear guideline on why we choose certain strategy and why. Is it because of the resources available, or is it the importance of it? So how do we prioritize our selection? Thanks.
Oh, thanks so much. It's a great question, and I think it's inherently a somewhat qualitative process. It's not something that's easy to quantify. And I think one of the most valuable steps is really community engagement. So trying to put together a team, getting them working together that represent the different perspectives to help you choose what's possible. Certainly, we all know that resource limitations will be one of the most important things. So is it feasible to actually do certain things that we want to do? We might want to hire mental health providers to exist in every clinic and have them see every patient, but that might not be practical, right? So that's going to be the first thing. Second thing I think is to think about where, and this is often where measurement comes in. What's the low-hanging fruit? So if we're just failing to screen everyone, that's maybe one approach. Or do we already have people that we've identified that we are providing services to? Maybe it makes more sense there to get some successes and see some of the benefits, and then we can have benefit by expanding the population. And then third, I think picking interventions that might have a good spillover effect. So if we can identify someone who has mental health challenges that can benefit from, and that may improve, let's just say, their HIV adherence. Now we've improved their mental health, but we also improved their HIV care. So that's just 3 examples of ways you might think about where's the best benefit for your investment.
Luke, as always, a tour de force, and looking forward to part 2 when you take us through the various different ones and how to select. I'm just wondering if maybe you could comment a little bit about the implementation science, where we're thinking about all of those things, as was stated, the complexity of it, and implementation practice, because I think that that's the place where many people are. And then, of course, a lot of the academicians are thinking about the science, but how the two of them will really help each other. I think that that is a really sort of key place, and maybe even a couple of examples of those differences, because I think that that sometimes is a struggle. I think we all heard, oh my God, that's so complex. You have a list of all of the things, the black box and stuff like that. But I think in other ways, for those people who are doing implementation practice, it helps them so that they can sort of see where the lines are in the road, if you will?
No, it's a great question, Rick, and I don't think we've come up with the answer exactly, but I think events like this, where we can talk with each other and sort of understand what are the main concerns that practitioners have. I think often with practitioners, timelines are really, really key. Accountability is very, very important. And trying to have a plan for when certain things are going to happen. I think for academics, innovating is very important. Trying to do not things in the usual way, but trying to do something different so we can really leverage the small impact that academics can have to have a bigger impact by finding new ways of doing things. I don't think it's possible with some of our traditional models of investigation, which emphasize, this one superhuman person who does everything, doing the policy, doing the research, doing the delivery. We really need to have twinning and teaming approaches. And so I think it's helpful for practitioners to kind of hear what some of this theory is, but also to partner with people that might have an afternoon, let's just say an academic, to write out a protocol and think about how all these frameworks work. But the practitioner, having been familiar with that, now can provide input and sort of say, just like the question that the last questioner sort of brought up, is this practical or is it not practical? So I think those are some of the strategies, and I'd love to hear from people in the audience here. What does implementation science to you look like? What is implementation practice? What is implementation research? To try to understand which things add value and which things don't. That's definitely an important reason for me to be here.
Good morning, I'm Adeeba from UNC IT position as well. Thank you for the two very excellent talks this morning on implementation science. And I think for most patients and also academicians here, we do this every day. We set guidelines, we set steps on how to carry out our clinical services, if you like. But how do you change the mindset of people? Most people just tell me what to do, what's the SOP, and I'll do it. But they're not very interested to work together with you in the process of it, and also not really interested in looking at the outcomes. I think one of the slides that Sten showed earlier on, looking into the cascade of how many people actually came for cervical cancer screening, if I'm not mistaken. And when you actually looked at it, then we thought we covered 50% or 50%, but we only covered 30%. So how do you get people to have that kind of mindset that we really need to look at it so that we can look objectively at your current practices, and at the end of the day, if you think that something is always important to look at the outcomes as well.
Thanks so much. A great question. And there were really two parts to your question that I think stood out to me. The first, and I'm going to be speaking a little more to the clinicians in the room. I am a clinician. There is a way that you're trained in medicine of trying to identify where the problem is first, and then trying to develop a differential diagnosis for what's causing that. And it's something that's just inherent in your training, and eventually people kind of forget about it. But I think it's also a very important approach for implementation science, because too often we start with the interventions and then we don't think about what the problems are. What's the differential diagnosis? If we don't get the right diagnosis, it's very unlikely that we're going to get the right treatment. So I think, first of all, I'd just like to highlight that as something that if you're working with clinicians and having trouble getting them to understand implementation science, you might make that analogy to help them realize that beyond just the individual patient, applying that mentality to a system, whether it's clinic level or beyond, can have a big impact. Second thing is, what do you do if that still doesn't work? And this concept of community engagement refers not just to the participants, it refers to practitioners as well. And it's really, really important as implementation researchers, as leaders, that we listen to where people actually are. We might want to get them to a certain place, but we need to understand what are the reasons where they are. Right now with COVID, a lot of people are feeling burnt out, overwhelmed. We need to kind of embrace that and understand what are the determinants of that, again, so that we can design interventions that would actually address that. And maybe just the final piece is, I've had experiences where, particularly working with people that don't have, they're frontline practitioners, they don't really have experience, say, looking at indicators or thinking in this kind of framework-based approach of how do we combine quantitative and qualitative information to make a change. And I think showing them how your indicators relate to what they do on an everyday basis, saying, okay, you know, we came up with this indicator, but really we got that based on how you're filling in this register and what you're doing with your patients. When you make it real and you connect those numbers to their everyday practice, a lot of times it brings up their inner competitiveness, their understanding that you know, what you're doing actually is relevant to what they're doing. I found that to be, you know, helpful in certain scenarios for improving the engagement of providers in this quality improvement or implementation of research approaches.
A very quick question. Thank you very much for the excellent talk. So when you talk about adaptation of an intervention, how much freedom we have as implementation scientists, like to adapt an intervention, because it might look like altogether a new intervention when we tailor an intervention to a specific context. So how much like liberty we have? Is there any mathematical modeling, like anything to understand this?
That's a great question, Romana. So, you know, traditionally in implementation science, when the term fidelity was first defined in some of the classic papers, it really was about to what degree is the intervention or the practice delivered as it was actually intended, or some of those people might say that the way it was delivered elsewhere when we tried to replicate that one here. And the idea that adapting it, that wasn't very well looked upon. But over time, people realized that there are adaptations that may be positive and there's maladaptations that may be negative. There's a lot of concern also that when you replicate something or you scale it, you may have kind of a loss of fidelity, or people sometimes call it a voltage drop, the high voltage being the original, and then later on it's sort of something that's less strong, less potent. And so what we really need to kind of differentiate, I think, is between what are the core components or functions of an intervention, and what is just the packaging of the way it can be delivered differently. So maybe a specific example, I kind of was inventing this example a little bit as I was talking on the fly, was delivering PrEP in different contexts, let's just say within Malaysia. It might have to be packaged differently in terms of how you introduce it, the service, how you describe it, how you counsel people, in order to fit the local culture and expectations of the context. And really, how much you can do, I think it comes down to evaluation. Are you able to ultimately get the same results? And so we like to have, across different settings, a common set of indicators for these key health outcomes and kind of just proximate to that, delivery outcomes. But within that, there should be a lot of flexibility for many schools of thought to contend and see what can actually work in different places. So, great question.